our brain is wired to exist in different states of consciousness, and there are benefits of that. Just changing mental state is a kind of brain model for us of taking different points of view about the same problem. And so the capacity to alter your mental state, be it with hypnosis or mindfulness or sleep or people self-medicating with alcohol or psychedelics, for example, which is getting a lot of attention right now, that there's something about being able to see the same problem from a different mental perspective that is inherently therapeutic. And if you then use that in a structured way to help people get that experience of seeing things from a different point of view, that's got tremendous psychotherapeutic potential.
This is the Thinking Mind podcast.
Welcome to the Thinking Mind podcast. Today, I'm very happy to bring you a conversation with Dr. David Spiegel. Dr. Spiegel is an American psychiatrist and the Associate Chair of Psychiatry at Stanford University. He's known for his research into psycho-oncology, the neurobiology of therapeutic hypnosis, and the role of the mind-brain-body connection in the role of the management of various conditions. He directs the Stanford Center on Stress and Health and is a recognized authority on hypnosis's clinical utility and the associated neuroscience. He's the author of more than 480 journal articles, 170 book chapters on hypnosis, and he's also published 13 books. As always, to new listeners, welcome. Here you can access conversations all about psychology, psychiatry, psychotherapy, self-development, and related topics. To our OG listeners, welcome back, and thanks everyone for listening. Hi everyone, we're back and have the pleasure of being with Dr. David Spiegel. Dr. Spiegel, thank you so much for coming on the program.
You're welcome, Alex. I'm glad to be here with you.
It's increasingly astounding to me that I get to have interviews like this and that I get to call it work. But these are the kinds of privileges that modern technology affords us. There's so much I'd love to talk to you about. In particular, your specialty in hypnosis, but in general, your huge amount of experience in psychiatry. One thing I think that's great about psychiatry is it affords us as clinicians the opportunity to immerse ourselves in human nature, to look at the human nature of the people we treat, but also our own. And something I'm curious about is, over the course of your career, what do you think has surprised you the most about human nature that you've learned?
Well, it's an interesting question. I would say, Alex, that somehow the old and the new, we live in an era that emphasizes progress, but there are certain fundamentals about human nature that don't seem to change very much. And I think there's this kind of dialectic between learning from our mistakes and perpetuating them at the same time. And you see that my late father, Herbert Spiegel, used to define psychiatry as the study of the diseases of theories. And I think in many ways it's true. I had the privilege of working at the Maudsley in 1970, when I was a medical student at Harvard. And it was a very refreshing experience to me because it got me to think about the course and direction of psychiatry. At Harvard, where I was a medical student, psychoanalysis was still very much the discipline in psychiatry and not very experimentally oriented. I found that somewhat frustrating, although I was interested in psychoanalytic theory, and I think it has made fundamental contributions to our understanding of what psychotherapy is and how the mind is structured. When I was there, I learned that Anna Freud had an office in North London, and I wrote her a note, and to my amazement, she wrote me a note back and invited me to an appointment. I've never felt so connected with a person I didn't know as her. She had these bright, piercing blue eyes. There were no half-truths. She asked me, if I told her both my parents were psychiatrists and psychoanalysts, and she told me, she asked me if I was going to become an analyst, and I was trying to be diplomatic and said, well, I wasn't sure yet. She said, so you're not going to be an analyst. I mean, she got it. And she said, well, psychoanalysis is in many ways a liberation from your parents. And that's hard to do when your parents are psychoanalysts, as she knew better than anyone else, of course, because her Sigmund Freud was her father and her psychoanalyst. And
that's rough.
That is rough, yes. And the other thing, I'll never forget, there used to be a Wednesday evening lecture and cocktails afterwards. And a remarkable group of people at the Maudsley. Sir Dennis Hill was kind of in charge and was sort of the classic descriptive psychiatry master. His interviews would take, an hour and a half or 2 hours, and started with time in the womb on up. And he would always save the zinger question for when the patient was presumably dismissed and was headed for the door. And then, oh, by the way, tell me about this episode with your mother when you were whatever or something. He would sort of get them when their defenses were down. It was very interesting. Hans Eysenck was there. And I remember the thing, I was just wandering around the room listening to conversations. And the lecture that month had been an attack on psychoanalysis, that it was scientifically indefensible. And, that certainly was the spirit around the Maudsley at that time. The main thing I heard was, I think, Eysenck saying, what I don't understand is why he wasted an entire hour of our time telling us something we already know. And I knew that lecture would have caused a riot at Harvard. I mean, people would have just been, and so it gave me a sense of humor about the diseases of theories and what works and what doesn't. And, there have been mistakes in being overly credulous about psychoanalysis. But on the other hand, at the Maudsley for a while, there was terrible criticism of lithium treatment for bipolar disorder, saying it was ridiculous, didn't work, couldn't work. So, it's easy to make mistakes in any in any direction in psychiatry. And it's a fascinating field. I find it deeply absorbing. I'm grateful to have had the opportunity to work in it my entire career. But, we've had our share of misdirections and mistakes in both directions, actually.
Something I've noticed, because I'm training in psychiatry and psychotherapy, and within those two, you see so many different schools of thought.
Right.
And something I've noticed is it's so easy for people to become entrenched in their particular point of view and to start to dismiss any information that might disconfirm things that they believe, and overemphasize, focus on excessively information that confirms it. And within psychotherapy, it's kind of mind-blowing, actually, and how often similar concepts are referred to with different language. And you come to the conclusion, my personal view is that there is a sort of tribalistic nature that people have, that they need to be quite proactive in overcoming. This reminds me of hypnosis in a sense, because the little experience, the little research I've done into hypnosis seems to suggest that it's about, to some degree, beliefs.
Well, you make a very good point, and Lord knows it isn't just psychiatry. I mean, it's politics, it's, everything around here, that we have become more and more polarized. And one of the things that I'm most disappointed about is the fact that the tremendous opportunity of having access to huge amounts of information on the internet, rather than leading to some blending and sharing of perspectives, has led to, echo chamber polarization. And you can find something that just confirms your belief. And you're absolutely right. There's been polarization in psychiatry across types of psychotherapy. Certainly in psychoanalysis, that was the case. There were all these different psychoanalytic institutes, and, interpersonal and classical Freudian, and they wouldn't talk to one another. And there was something of a sort of priesthood about it. You had to go through your own personal psychoanalysis to become a member of the priesthood. and how you could do an actual free psychoanalysis with somebody who would be deciding whether you would move ahead in your career, your training analyst, is something I never really understood. You can't freely associate if that's what's going on in the room. So I think, and in different schools of, I think the desire for evidence base is crucial, and doing empirical examination of what we do and how we do it and what the results are is crucial to making psychiatry an effective science of treatments. But I agree with you also that it's just been far too polarized, and just, one school disrespectful of another, and that doesn't get us anywhere really. So I think both the division between biological treatments and psychosocial treatments, and among these different treatments, and one would hope that we would rise above that a bit. And hypnosis is, as you mentioned, a perfect example. It's the oldest Western conception of a psychotherapy. The first time a talking interaction was thought to have therapeutic benefit. And it's an old battle. Mesmer had this strange theory of animal magnetism, that there were magnetic fields floating around, and that the fields went awry in patients, and that's why he had hysteria or some other psychiatric illness, and that if he put his magnetic fields next to theirs would get better. I don't know why his wouldn't get worse, but the magnetic field theory was wrong, although he may have been a forerunner of transcranial magnetic stimulation. I'm not sure, but he, as soon as he got some success in Vienna doing it, he left his wife and family there, moved to Paris, and took on the biological medicine of the time. And, the major treatment at the time in France was bloodletting. France was the world's leading exporter of leeches. I remember Voltaire wrote to his brother when their father died. He said, "I did everything we could to save father's life. We even sent the doctors away." And, there's this prejudice, and it's one of the things that frustrates me the most in my career, frankly, is the sort of bottom-up idea that the only real scientific approaches are bottom-up biological approaches. Fix the body the way you fix a broken car, replace the muffler, injection, ingestion, incision, those are the only real treatments.
As opposed to ways where you can allow the mind to have an influence over what's happening in the body.
Absolutely right. And wouldn't it be weird if our major evolutionary advantage as a species is this 3-pound organ on the top of our bodies. It allows us to think, plan, form social relationships, remember things, communicate. It's connected to every other part of the body. It regulates every other part of the body. And wouldn't it be weird indeed if this major evolutionary advantage was pretty much useless in repairing problems when they occurred? It's just wrong, and hypnosis I think of as a user's manual for the brain. It's a way to use our brains in ways that we hadn't fully understood and explored. Now, when Mesmer introduced that in France, he got investigated by a French panel of experts, that the king pulled together to examine and eliminate his treatment. He was competing very effectively against French physicians because he had a cheerful, bright office. He was talking to patients. They were talking to one another. And, if you did a randomized trial then, sending every other medically ill patient to Mesmer or a French doctor, Mesmer would have come out way ahead because they were killing people with bloodletting, and unless you happen to have polycythemia vera or congestive heart failure, you were more likely to be killed than helped. And on the commission, by the way, was the brilliant French chemist Lavoisier, who came up with the principles of oxygen chemistry. He also, just before he was beheaded in the French Revolution, came up with the notion of the gross national product, so a major contribution to economics. Another member of the panel was Benjamin Franklin from the US, who was having a lot of fun in Paris at the time. And a third member was the famous Dr. Guillotin, the inventor of the guillotine. He sort of created the mind-body problem. And so Mesmer was, disgraced and basically driven out of his practice by King Louis and the current French physicians. So if you want one more historical example of destructive polarization and thinking about psychiatry, there it is. And we've been trying to rebuild that ever since. A famous British surgeon, Braid, went to India and was using hypnosis as the sole anesthetic for amputations, which were the major surgical treatments in India at the time for limb infections. And he was reporting 80% surgical anesthesia with hypnosis. And at Mass General 10 years later, when they introduced ether in what is now called the ether dome, a surgeon strode to the front of the amphitheater and announced, "Gentlemen, this is no humbug," to distinguish what they did with ether with what Braid did with hypnosis. And Braid said, "Well, they're getting 90% anesthesia. I only got 80%. I withdraw the finding." And, so it's taken us more than 100 years to figure out that the brain actually does have something to do with analgesia and pain control and can be useful.
And that the brain has a plasticity, a malleability to it.
That's correct. That's correct.
Because you mentioned thinking about the brain, mistakenly thinking about the brain as a machine for which you can repair spare parts, and that's interesting because I think whatever analogy you use to try and conceptualize the brain, you become limited by that analogy. Like the brain is kind of a machine, but actually way more. Even if you use the more advanced technology, like you say, oh, the brain is a computer. Actually, the brain is way more than a computer, because a computer, unlike the brain, doesn't have the ability to shift and change and rewire itself.
Well put.
The way the brain does. The other historical point I was thinking of, my psychodynamic supervisor told me that Freud actually was inspired to think of the unconscious mind while viewing Charcot hypnotizing.
That's exactly right. Freud exchanged translating Charcot's work from French to German for his sitting in on Charcot's lessons in hypnosis. And his earliest work involved hypnosis, and as a way of getting to the unconscious mind. And it's obvious, hypnosis is related to dissociation. That's one of its components. And so things may be working in your brain that you are not consciously aware of. And Freud demonstrated that. He was using it for treatment. And he wrote in his autobiography, there's the moment that he gave up hypnosis. He said, "I was relieving a woman patient from her attacks of pain by tracing them back to their traumatic origins, when she threw her arms around my neck." He said, "I was modest enough not to attribute this event to my own irresistible personal attractiveness. And so in order to control it, he discovered transference at that moment." And he said, "I was relieved from a further discussion by the unexpected entrance of a manservant into his office." And so Freud discovered transference. He didn't like patients staring him in the eye, and when their eyes were open, they would be doing that. So the reason there's a couch in psychoanalysis is because he had a couch for hypnotizing people. So he moved his chair around behind the head of the couch so they wouldn't be staring at him, and had them free associate. But you're absolutely right. The brain is a marvelous and much more complex piece of equipment than a computer. And the idea that there would be nothing useful in treating people by helping them to use that brain better is such a waste, and it's possible to make mistakes and false statements and bad treatments biologically as well as psychologically, and we've done plenty of both. But there are tremendous opportunities, and I've found in my own career that there are so many opportunities to help people rapidly and effectively using hypnosis that it's a shame that it's been sort of viewed as a stage show trick or just a mistake or worthless. It's just wrong. It's a waste of a tremendous resource that we can use.
And do you think it's purely because of this unfair stigma and its general sense of unconventionality that it's not more widely taken up? Because in the UK, mental health services, it's starkly absent. And you know, I work for the National Health Service, which is constantly looking for treatments which are fast, effective, cheap. Hypnosis seems to check all those boxes, you know. Do you think that's the reason,
Absolutely.
or are there other reasons?
Well, I think I have a modest proposal, by the way, that I'll present for you in the NHS, but I I think that's part of it. I think of it as Alex, dangerously effective. You know, people are afraid that
Mm,
hypnosis is an opportunity for somebody to take you over and control your mind and make you do anything they want.
that's a good point.
We published an article in Scientific Reports a year ago showing that what you really see in hypnosis is cognitive flexibility. What's called suggestibility is cognitive flexibility. You can let go of you turn down activity in the posterior cingulate cortex and the default mode network when you're active, and more so when you're active in hypnosis. So you're able to act in a way that disconnects you from your habitual ways of thinking and doing things. That's a tremendous therapeutic opportunity. And yet it scares people. They think, oh my God, you know, the football coach danced like a ballerina for this stupid hypnosis stage show. And it ought to be a lesson to us that, look, people can change. They can narrow their focus of attention. They can dissociate aspects of their ordinary assumptions. And that's a tremendous therapeutic opportunity. And instead, we see it as either dangerous or stupid. The height of it was 100 years ago when automobiles were being invented. They wanted to do something about cleaning the windshield, so they wanted windshield wipers. And there were laws being passed that they were illegal. Why? Because they thought drivers would be hypnotized. You remember the old dangling watch thing? Well, it doesn't happen. There are a lot of windshield wipers. Drivers haven't been hypnotized. And um, I I got so, you know, I thought when I started my medical career that if you just do enough research about it, if you just prove, you know, and provide evidence, you know, randomized clinical trials, people will use it. We published a paper in the Lancet in 2000 with my colleague Elvira Lang at Harvard, randomized trial, 241 patients undergoing invasive radiological procedures, cut downs into the arteries, chemoembolization in the liver, visualizing strictures of arteries, renal artery stenosis. And you don't use general anesthesia for these procedures, but they're long and uncomfortable. And we had three conditions: standard care, which meant pushing a button and you give yourself IV opioids. The second condition was that plus a friendly nurse providing emotional comfort. And the third was hypnosis. And after the procedures lasted usually 2.5 hours, after an hour and a half, the pain ratings in the standard care group were 5. There were 3 in the nursing support and 1 in the hypnosis condition. You know, about 80 subjects in each group. The anxiety levels were 6 in the standard care group, 4 in the nursing condition, and 0 in the hypnosis group after an hour and a half. I thought they died or something. They were fine. The procedures got done 17 minutes quicker on average because the patients were more comfortable, but you know what? So were the staff. You know, they weren't seeing somebody suffering beneath them. And the standard care patients were using twice as much opioid levels as the other patients. So they had half the meds, more comfortable, and fewer complications as well because of the lower opioid use. So now you publish that in the Lancet, randomized trial. If that were a drug, everybody in the country would be using it, right?
Because it would be more it would be a more acceptable idea. Ironically, it's almost as if the medical establishment requires more cognitive flexibility to accept the possibility of an unfamiliar treatment.
That's very good. Well, I've been trying to hypnotize him for quite a while, but yeah. But you're absolutely right. We have this false equation between biology and science. If it's biological, it's scientific. If it's psychological, it isn't. That's the prejudice. And it's wrong. It's just wrong. Just look at the evidence, you know, what works, what doesn't work. And you know,
I do think medicine, particularly modern medicine, seems to select for people who are less likely to be open to new ideas, I think, and more
ah,
likely to be good at assimilating old ideas. And because modern medicine is so algorithmic, you know, medicine used to be a lot more dangerous but adventurous. It was all about discovery. And now medicine seems to be, obviously it's safer. It's more about careful implementation of pre-established algorithms, unless you're in research, obviously. And when I presented a journal once, a small study, I believe out of the University of Arizona, a group that I was looking for an unconventional study because I'm that way inclined. And I found a study where they wanted to examine whether or not raising someone's core body temperature would have an effect on their depression scores. So it was a small randomized controlled trial, a convincing sham in one group, fake. They didn't actually do anything to their body temperature, but it seemed like they were. And then another group where they raised their body temperature by 1 degree for some period of time, something like an hour. And there was like a demonstrable effect on their depression scores weeks later. And it was a small study, small but well conducted. And my supervisor commented, well, there's nothing wrong with the study. It's small, but it's well conducted. It's in a reputable journal. I don't know why. I just don't like it. There was just this kind of reflexive, because it was like weird, because it was strange. We have like a reflexive attitude to strangeness, I think.
Yes, I think you're right. And so that's where cutting loose, turning down activity in your default mode network and just allowing yourself to examine the present evidence rather than how it matches your predisposition to believe something is very important. And that's the essence of scientific method. We published a paper in The Lancet in 1989. It was a randomized trial of women randomly assigned to standard care for metastatic breast cancer, or a year of weekly support groups, helping them deal with their fears of dying and death, learning to feel better about themselves by helping one another, a sort of helper therapy principle, communicating better with their doctors and their families. And I taught them self-hypnosis for pain and anxiety control. And we discovered, and we were at the time, this was in the 70s, we were informed that by oncologists that we would demoralize them because they would see one another die. The average survival time was 2 years with metastatic breast cancer, and as though death was a novel concept to a cancer patient, right? I mean, half of all people diagnosed with cancer will live to die of something else, but everybody that's diagnosed thinks it's going to kill them. And the women not only were less anxious and depressed at the end of the year, randomized trial, with 86 subjects in the study. They had half the pain the control group did on the same and very low amounts of medication. And the big surprise was it turned out that they actually lived 18 months longer on average. Now, most of them eventually died of breast cancer, but there was a significant survival advantage. And there was an editorial when The Lancet agreed to publish it by a terrific doc, I'm sorry, I don't remember his name, who said, it is really not about, he said, the methods seem to be beyond reproach. It's a randomized clinical trial. So it's not the treatment on offer that matters, it's the results. And that's why they published it. But still, there are people that can't believe that could have happened, And, we did a replication trial 10 years later. We were able to reproduce that among the estrogen receptor negative patients, the ones who didn't respond to tamoxifen. There wasn't much hormone receptor blocker being used in the 70s. And since then, survival has improved substantially by the use of hormone blocking. But the ones who weren't capable of benefiting from that still showed better survival in the treatment group. So, it's one of those things. I've been struggling with that my entire career. It's not about our prejudice or beliefs or how plausible it seems. It's about proof whether or not it works. And we do have this prejudice against the idea that using your brain differently will affect your mental state and also your physical state, but it can.
And I think it's normally the pattern that I seem to observe is that something is unconventional until it reaches some critical point.
Right.
And then usually when its utility is undeniable, it's everywhere. And I think mindfulness meditation is a good example where you go back in time a few years, meditation seems to be something extremely unconventional, and now it's all over our NHS websites, and it's all about the apps. We'll talk about your app as well, and it's very widespread. It reaches a critical point, and all of a sudden it's very mainstream. As I've been looking into hypnosis research preparing for this interview, I've been thinking about different states of consciousness because that's kind of what we're talking about, a hypnotic state. I have quite a lot of experience with meditation, and I've been thinking about flow states. And one question I had for you is, do you think that these different states of consciousness exist in discrete categories, or is there significant overlap? Is it more of a spectrum rather than having distinct buckets of distinctly different states of consciousness?
Well, there are areas of overlap and difference, but I think your fundamental point is right, that our brain is wired to exist in different states of consciousness, and there are benefits of that. We have to sleep every night, and you get a nasty email at 11 o'clock at night and you're all upset and you don't know what to do. And the next morning you wake up and you think, oh, that idiot, I can deal with him. So just changing mental state is a kind of brain model for us of taking different points of view about the same problem. And so the capacity to alter your mental state, be it with hypnosis or mindfulness or sleep or people self-medicating with alcohol or psychedelics, for example, which is getting a lot of attention right now, that there's something about being able to see the same problem from a different mental perspective that is inherently therapeutic. And if you then use that in a structured way to help people get that experience of seeing things from a different point of view, that's got tremendous psychotherapeutic potential.
Yeah, and funnily enough, when I'm doing psychotherapy with clients, sometimes what I'm aiming for is very much a different mental state. And that mental state is, there's a particular look in the eyes, and you can tell that the client doesn't know the next thing that they're going to say. They're speaking in such a spontaneous way. And that's how you know they're in the zone of self-discovery and of covering new psychological ground.
Right. You're absolutely right. And you get in that mode too. It changes you as a therapist. And I find that when I'm doing good therapy, I almost don't know how I come up with the next thing I'm going to say to a patient. But when I'm really tuning in, it's not from some pre-program. I mean, there are things I, in general, would do and think about doing, and things I would never do. But other than that, I'm trying to just really get connected and tune in with the patient and respond for them with what I think needs to be the next thing. I can give you an example. Recently, I was treating a woman who came from one of the countries that is famous for mistreating women. And she, when she was 12 years old, was raped by her landlord. Her parents were afraid to do anything, to get thrown out of the home. She said, as I grew up as a young woman walking the streets there, I realized my body was not my own. Men sort of thought themselves entitled to think, say, or do whatever they wanted. And she finally got out of that country and was working as a healthcare professional in the US, but was very depressed and quit her work earlier than she needed to. And I was feeling that, it was a long time ago, but this was a kind of post-traumatic depression where she was just, and, many rape victims blame themselves, you'd rather feel guilty than helpless. I should have known better than to whatever, and they're often blamed by abusers. Sexually abusive men will say, you were being seductive, some 12-year-old girl. And so I had her she was very hypnotizable. And I said, I want you to picture yourself as your 12-year-old self. I want you to just look at that. And she started to cry. And I said, and I want you to kind of pretend you're her mother. What would you do? And she said, well, I'd give her a hug. And I said, is it her fault that this happened? And she said, of course not. She was a sweet little girl. And she said, I'm stroking her hair now. And so it was a way for her to kind of reconnect in a different mental state and with a different point of view about what had happened. And it was sad and painful, but she was just, sitting there stroking the hair of herself as a 12-year-old girl who had just been raped. And she called me about a week later And she said, my psychiatrist wants to know what you did to me. She said, he can't understand it. I'm not depressed anymore. And my friends don't recognize me. They say, what did you do? And so sometimes you can just, get people to use this altered mental state to have an altered perspective on something that happened. And I've seen it very helpful with post-traumatic stress disorder. You help people see what they did to protect themselves, to just see it from a different point of view. And they still have intrusive thoughts, but they're very different because it isn't all bad. They can feel proud of themselves for how they did the best they could under a circumstance they didn't control. So there's tremendous power, as you say, in altering our mental state and seeing the same situation from a then radically different point of view.
I've heard you say that the essence of trauma is helplessness.
That's right.
And I wonder if you could expand on that a little.
Well, what is trauma? People have pain and they have fear, but that doesn't constitute trauma. The essence of trauma is being made into an object, a thing. A building collapses on top of you in an earthquake, or somebody beats you up or rapes you. You're suddenly, your agency, your sense of agency is suspended. And that feels worse than anything else. You can't control what's happening to your body. And so the intrusions, flashbacks, the irritability with post-traumatic stress disorder are about feeling. I've often wondered, if you think about it, exposure-based therapy works for PTSD. So why don't flashbacks cure themselves? If you're reliving the trauma spontaneously by having a flashback, why isn't that exposure therapy, prolonged exposure?
And I think the key there is because the secret ingredient of exposure therapy is that the exposure is voluntary rather than involuntary.
Absolutely right. Absolutely right. So you're not being reattacked by whoever or whatever attacked you.
You're going into the situation of your own volition.
Right. Your own volition. You're doing it in controllable pieces, and you're changing your perspective about what happened. And you're exactly right that's the difference. And so it's a shame. And with hypnosis, you can do that intently. And one of the good things about hypnosis in doing this kind of trauma work is you can turn it on and you can turn it off. There's a sort of clear beginning, middle, and an end in a hypnotic state. So you're focusing on this, you're experiencing it, you're restructuring it in some way. I use a split screen to have a picture something about the assailant on one side and what did you do to protect yourself on the other. You have feelings about that, and then you can stop it. You can say, okay, we've had the hypnosis exercise for now, let's put it aside.
So it's discrete, and because it has a disassociative quality, it feels safe. You're separated from your emotions.
Right.
Is that right?
That's right. And that's what people do during trauma. I mean, they spontaneously dissociate. Most rape victims experience the rape as if they're floating above their bodies, feeling sorry for the person who's being attacked below. I treated a woman who was in the World Trade Center when it was attacked, and she was dissociating on the way down. The elevators weren't working. They were going down the stairs, and she's saying, "I'm telling myself if I just get to the ground floor, I'll be okay." And she did get to the ground floor, and then the other building collapsed, and she got blown through plate glass window. She survived it, thank God. She was angry with herself for having promised herself that she wouldn't be hurt if she just got to the ground floor. She was that dissociated, and it saved her life. I mean, she figured, and that's what I helped her to do with hypnosis, is to, recognize and accept the fact that she had saved her life by distorting. You don't want the big picture when you're in the middle of a trauma like that. And so the capacity to dissociate is protective during trauma. The problem is it can go on uncontrolled after the trauma is over, and then it becomes part of the PTSD, and that's how you need to control and manage the dissociation.
I like to think of it like psychological scar tissue. It's useful in the short term to plug the wound, but it's problematic in the long term, as scar tissue tends to be when it is in your organs, causes problems.
That's a good metaphor. Yeah, it's a good temporary fix, but it's not good for the long term.
I love the parallels between the way the body works physically and psychologically. There's like a beautiful symmetry to it.
Yes, yes, I think that's true. They learn from one another.
Yeah. And we've talked a little bit about dissociation, and another drug that's becoming more popular is ketamine, which is a dissociative analgesic. It's used in this country, in England, and I believe in America as well, for treatment-resistant depression. There is actually a ketamine clinic, a small ketamine clinic at the Maudsley now, and I was there last week, and we were speaking to a patient who has been getting treatment for around 18 months. He was severely depressed before, and said he had a basically slow and steady recovery since starting the treatment. He got a much better job, improved his living situation, is getting married. His mood has improved drastically, basically has no signs. His depression score is 0 at the moment. And what he said was very interesting, which was the ketamine did not lift his mood the way he had experienced antidepressants in the past, lifting his mood. But ketamine allowed him to think differently and to see opportunities where he previously didn't see any opportunities, which sounds a lot like hypnosis. And do you think the dissociative quality of ketamine could be part of what's helping?
Yes, I do think it is. The ketamine treatments are interesting and complex. There's been one randomized trial that showed that naltrexone partially blocks and reverses the antidepressant effect of ketamine. So there may be an opioid-mediated pathway as well. But on the other hand, there is absolutely, if you think about, as you're talking about this, I'm thinking about CBT for depression, right? That you have this interaction between mood and cognition that you try to alter with CBT. And, you tell a depressed person 9 good things and 1 bad thing about themselves, and what do they remember? The bad things. So what your patient is describing is a disruption of that reverberating circuit where your mood starts to reflect your cognitive misevaluation of yourself and your value and who you are. And in particular, what's pretty interesting about it is that many of these mood altering or state altering treatments, including mindfulness and hypnosis, have an effect on the posterior cingulate cortex. And Carl Diceroth at Stanford, he just got the Japan Prize. He's a brilliant psychiatrist. Has published a paper in Nature where he, in mice, showed that rhythmic activity, they would use optogenetics to induce rhythmic activity in the retrosplenial cortex near the posterior cingulate, and it would be dissociogenic. It would, and he found that he showed it by using a hot paw test, and they stopped withdrawing their paw from a heated plate, as if they were having a dissociative reaction to the pain as well. And he found this rhythmic connection between the PCC and the prefrontal cortex that was dissociogenic. And then the cool thing in this Nature paper, I love this, they had a patient who had intractable seizures and had an electrode implanted in his posterior retrosplenial area. And when he was having one of his dissociative seizures, he had the same rhythmic pulse from the retrosplenial region. And he said, I feel like the pilot of an airplane who stepped out of the cockpit while the plane is flying. It's a really nice description of dissociation. So yes, absolutely. And what you find in meditation, Judson Brewer has shown that that experienced meditators have reduced activity in the PCC, and that fits the cognitive experience of mindfulness, in that you're trying to disconnect from selfhood. You're trying to get over yourself and just experience things rather than experience them as this particular person with this set of experiences and so on.
I've heard you make the distinction between the evaluative self and the experiential self, which I find very useful. There's the part of us that's always judging, is it good, bad, hot, cold, etc., versus the person that's just present, having an experience.
That's exactly right. And that's the goal in mindfulness. And the main thing you see in experienced meditators is reduced activity in the PCC, which makes perfect sense, that's what would be happening. With hypnosis, it's a little different. we see reduced activity in the dorsal anterior cingulate cortex. So the salience network goes down. And that makes perfect sense, because if you're not screening for potential threats or something like that, you're more likely to be totally immersed in the focal experience, which is what happens in hypnosis.
So what makes hypnosis distinct from meditation is it turns down the activity in a part of the brain that is looking for threat or
That's
conflict.
right. That's exactly right. That's exactly right.
Yeah, so it makes you more likely to accept a novel idea.
Right, a novel idea. That's part of the cognitive flexibility. That's well put. That's exactly right. That you're not judging and evaluating. You're just taking it in and seeing what you see. And the third thing we found is higher functional connectivity between the executive control network, the DLPFC, particularly on the left, and the insula. And the insula is part of the salience network, but it's a part that's this mind-body pathway.
So the insula is part of it connects to the body, say?
Yes, that's right. It's one of the major pathways for both interoception, for getting information from the body, but also providing information to the body. We did a study years ago where I worked with a gastroenterologist, and we put down nasogastric tubes. And after in the morning, people were NPO, and I had them eat imaginary meals in hypnosis. And one woman said after half an hour, let's stop, I'm full. She's just imagining eating food. I was getting hungry just listening to them say what restaurant they'd like to be at. And we got an 89% increase in gastric acid secretion just from eating imaginary food. Then we did the reverse. We had them do something relaxing that didn't involve eating or drinking, and we got a 40% decrease in gastric acid secretion. So just in hypnosis, thinking about food one way or another, we could control the secretion of gastric acid. And then we injected them with pentagastrin, which stimulates maximal parietal cell output. We still got a 19% decrease in the non-eating condition. So the brain has remarkable abilities to control.
So it really demonstrates that the brain can manipulate what the body does.
That's exactly right. That's exactly right.
Let's talk a little bit about your app. So you've made an app called Reverie, which is designed to allow people to participate in self-hypnosis.
That's right.
In order to achieve certain goals. And the goals I saw on the app were things like sleeping better, focusing, stress reduction, eating better, stopping a bad habit like smoking.
Yes.
So are those like the typical utilities which hypnosis is particularly effective for?
Yes, and pain control is the other one that is very effective.
Yeah.
And there are others. I use it for trauma, as we talked earlier, but that tends to require more, psychotherapeutic structure around it. But yes, those are the most common things, and also irritable bowel syndrome. There's a British psychiatrist, Horwell, has done some very good studies on that. But those are some of the major things for which hypnosis can be used. And what in doing this, I was giving a talk at a Brain Mind Summit at Stanford about 4 years ago. And this very nice guy came up to me. Ariel Poehler is his name. And Ariel went to MIT and then Stanford Business School. And he said, this is pretty interesting. The Alexa now has this, app that will process speech and respond based on what you say. Would you like to try building a hypnosis app on Alexa and seeing if you can do something like get people to stop smoking? And I said, I'd love it. Let's do it. So he said, I'll program it. It's easy to do. So we did it. We had people listening to the app, and it's interactive. What's different from these old tapes about, these long, boring hypnosis tapes is that I would ask a question, is your hand floating up in the air comfortably? If they say yes, I go on to the next thing. If they say no, then I work on the hand some more. And so similarly, we can I wanted to make it as much like the experience of being in the office with me as possible. So we did with smoking, what I tell people is, for my body, smoking is a poison. I need my body to live. I owe my body respect and protection. So you focus on what you're for. You wouldn't put tar and nicotine into the lungs of your child or your pet. Your body's as dependent on you and as your child or your pet. And so you can feel good from the moment you do this, that you're affiliating with a positive behavior that you know is good for living creatures. So just do it for
You're
your body.
creating motivation and a compelling goal to work towards.
Right. Plus immediate reinforcement. The best way to change human behavior is intermittent positive reinforcement. So you can feel good from the moment you do it. You're not focusing on the craving. They used to put up signs on highways in the US, "Are you dying for a smoke?" And people, very clever, and people would say, "Yes, I am," and they'd take a cigarette. So instead you focus on what you're for. We got 19% abstinence after doing this, and that's as good as most varenicline and bupropion and other meds. So I just thought, so then Ariel said to me, "You know what, we need a company." And if you're a Stanford professor, you got to have a startup. I mean, it just goes with it.
It's the in vogue now.
Yeah, that's right. And so we formed this company, Reverie, and hired some engineers, and it's now a very nicely functioning app that you can download if you have an iOS phone from the App Store, if you have an Android phone from Google Play, and you can interact with it, use it anytime you want. I used to think, Alex, that I wanted it to be something like as good as sitting in the office with me. But I'm beginning to think it might be better, because if you wake up at 3 a.m. and need help going to sleep, I'm not going to be in bed with you to help you get back to sleep. So, yeah, terribly. So, but you've got me on your smartphone, and people love it for going to sleep. That's the most popular use right now.
So some people are more hypnotizable than others.
Yes.
And I have heard you say that it's possibly there's a genetic influence, which isn't surprising, really.
Yes.
One question I had is, have there been any studies examining correlations between hypnotizability and personality traits? And I'm thinking of, for example, taking the Big Five model, traits like openness to experience seems like one that might predispose, or agreeableness and empathy.
You would think that's true, and this has been studied very thoroughly. And the odd thing is, no, hypnotizability doesn't seem to correlate highly with any of the Big Five traits. And the two you picked on would make sense. However, it does with another trait. Aukie Tellegen at the University of Minnesota did a number of studies on what he calls absorption. So the tendency to lose yourself in a sunset or a movie, get so caught up in a good movie that you forget you're watching a movie, absorption. And that is correlated 0.6 with hypnotizability. So it's a narrower, more hypnosis-like trait, but it also underscores something else, that people who are hypnotizable have been in hypnotic states throughout their life. And they didn't call it that or recognize it as such. But I have people who are really highly hypnotizable. I say, "Did you ever go through getting a cavity filled in the dentist's office without any Novocaine?" And they'll look at me and say, "Yeah, I just told the dentist I don't need it. I'm just going to go somewhere and do whatever you have to do." And he was sort of uncomfortable about it, but I was fine, And so you find that people who have that trait tend to use it anyway.
And when you're studying it scientifically, how do you distinguish between someone who's highly hypnotizable and a placebo, i.e. someone who really wants to believe that they're hypnotizable? Is it by using like a fake version of hypnosis, a sham?
No, I use a test called the hypnotic induction profile. It takes about 5 minutes, and I use it with every patient I treat. It's part of my initial evaluation. And right now we actually have it for the first time on the app. So you can do...
Yeah, I used it.
Oh, did you? Yeah, what was your score, Alex?
8.
8, good. So you're pretty hypnotizable. That's great.
Very much so, yeah.
And so what I do is I tailor my approach to the treatment based on what I know about their hypnotizability. So someone like you, I would just say, let's just go and do it. In fact, even when I'm sure you're not a smoker, but you immediately affiliated with the concept and got it right away. This is what you do. And so for someone like you, it would be fast, efficient, and I would just say, let's go there and I'll show you what to do and you can do it. And you could do it. For people in the mid-range, it's more of a balance between cognitive and experiential approach, where I explain more about what I'm doing and why I'm doing it. And the thing I told you later about, positive reinforcement, and take a moment to feel good about what you're doing rather than focusing on the craving, that kind of thing. So it's more a balance between the experiential and the cognitive. For people on the low end of hypnotizability, I sometimes just say, let's not pretend we're doing hypnosis. We're not. But let me explain to you how to approach the problem, and let's work on that together. So those three kind of general approaches are things that I use based on my assessment of hypnotizability.
I tried the healthy eating hypnosis.
Yes.
And I found the whole experience very interesting. I felt extremely relaxed in a way that I associate with meditation, but meditation is a lot less reliable in inducing that state.
Interesting.
And this was a lot faster.
Interesting.
And I also obviously noticed, because I didn't know what to expect, that you were using the hypnotic state as an opportunity essentially to implant extremely positive and helpful beliefs about how to eat, similar to what you mentioned about smoking. You know,
Yes.
your body is defenseless, you should take care of it, take care of your body, and your body will take care of you.
Yes.
And so it was very I could see how it could help, because we normally go for bad habits by trying to almost bludgeon ourselves against them in a very direct fashion.
Right.
Whereas this is actually saying it's not about the habit. The habit is almost irrelevant. It's like, what relationship do you want to have to food and to your body?
Yes.
Like, that's the question.
Right.
Really.
Right. That's exactly right. That's a very astute way of understanding what I'm trying to do and doing it. And as you describe it, it sounds appealing, right? It's not unpleasant. I'm not depriving myself of anything, you know. And I find actually one of the things I say in this is you can learn to eat like a gourmet. You can actually enjoy eating more while you eat less. The amount of pleasure you get from eating is not related to the total amount of food you put in your mouth. And so many people who overeat don't pay attention while they're eating. It becomes a sort of mechanical experience, and you can learn to enjoy it more even as you eat less.
And presumably, the more often and the more consistently you practice self-hypnosis for a given objective, the more likely it is to work. Is that fair to say?
That's absolutely right. We found a relationship between the number of times people do it, and because you are, look, you know, your brain is a competing rostrum of ideas and impulses. And if you are kind of reprogramming it in a way by focusing on these relatively novel approaches to the problem, you're still competing with the times when your brain wants to slip back to the old ways and do it the other way. So if you pay some attention to the discipline of doing this, you'll tend to get more airtime for the approach that works better.
And were you guys able to identify a kind of minimum effective dose?
We're working on that now. I don't have a number yet. We're actually analyzing now data from the use of the app, and we want to address that problem. I don't know what it is. I know that more is better, but I don't yet have the number. But one of the nice things is, again, from the immediate reinforcement point of view, is that where we ask people to rate their stress on a 0 to 10 scale, we're finding that within 15 minutes, we get a 35% reduction in stress levels. And the same is true for pain. So the nice thing is you have an immediate experience that it can help you. And that's one thing that's different from mindfulness, where it takes a while to kind of shift into the mode where those things begin to happen. And hypnosis is more Western, more problem solving. If you're going to get a benefit, you're likely to feel it very quickly.
Yeah, if I had to compare the two, I would say the strength of mindfulness relative to hypnosis is mindfulness has more practical philosophical implications about how you view yourself, your direct emotional experiences, and the world. And it's perhaps mindfulness is more appropriate for developing more equanimity with life's vicissitudes, you know. whereas hypnosis is like a targeted, you have a problem, it's a targeted surgical strike. But what is so interesting about it is, what's interesting about hypnosis is it highlights that people believe things at different depths. You can believe something up here in your brain, for those listening. You can believe it emotionally, and you can even, I think there's a deeper layer somatically, in your body. And something you encounter all the time in psychotherapy is people who say, well, yeah, I believe it intellectually, but I don't feel it.
Yes.
There's a shallowness to the rational belief, and presumably hypnosis is a tool to help you access things at a deeper level.
That's an interesting way of describing it, and I think you're right. Or it's a way of kind of bringing into alignment these deeper and more experiential elements with the cognitive ones. Yeah, sure, I understand it, but I can't do it, or I don't want to do it. And this is a way of making this new approach more appealing and attractive, and recruiting the experiential and emotional and somatic elements as well. You feel better. You mentioned the first thing, you just felt more quickly and deeply relaxed than you usually do. So that's an appealing entrance for an idea to say, okay, so you'll feel good while you're doing this, and here's what it is.
Because going back to Freud, one of the really useful things he highlighted was a lot of our suffering is not from our circumstances exactly, but it's from internal conflict. I want one thing, and yet at the same time, I want something else. So you use the word alignment, which I think is perfect, because it's like you're getting the different parts of yourselves at the different levels. You're getting everyone rowing in the same direction.
Right. That's true. That's a good point. It's it's not id versus superego. It's bringing it,
because a lot of the struggle is how do I arrange my life so that things will work today, in 6 months, and in 10 years. And how do I, that's one dimension. And the other dimension is how do I arrange it so it works well for me, but also the people around me, and also my broader community. So it's like this really, like, and how do you choose what to eat, sort of based on those two dimensions,
Right.
And it's hard because if the world was ending tomorrow, pizza and cocaine would be a good idea. It would be fine. It wouldn't make a difference. But it's because we live long lives, and because we affect lots of people.
Yes.
We have to be very delicate in our decision making.
Well, the way the world is going these days, get the cocaine and
bust out the pizza and cocaine.
Right.
JK, everyone. So Dr. Spiegel, it's been an absolute pleasure. I could talk to you for way longer, but unfortunately we're restricted by the bounds of time and space.
I understand. Well, I really enjoyed it too. It's great.
It's been a pleasure, and great. I'd love to have you back on at some point in the future.
Good. I'd be happy to do it, and keep up the good work, and keep carrying forward the standard for using the brain and doing psychotherapy. That's great.
Great. Thanks, Dr. Spiegel. Have a great day.
You have found the Thinking Mind podcast.
If you enjoyed today's podcast, we'd love it if you share it with a friend, or you could give us a rating on Apple Podcasts, Spotify, or wherever you listen. If you fancy it, you can even buy us a coffee to support the team, and the links for that will be in the show notes. Thanks for listening.